In this module, we're diving into Medicare Part D, the program that provides prescription drug coverage for Medicare beneficiaries. By the end, you'll have a solid understanding of how Part D works, the types of plans available, and how beneficiaries can make the most of their coverage. Medicare Part D comes in two main forms. First, there are standalone prescription drug plans, or PDPs, which provide only drug coverage. Then, there are Medicare Advantage prescription drug plans, or MAPDs, which combine regular Medicare benefits with prescription drug coverage in a single plan. Eligibility for Part D is generally for anyone with Medicare Part A or Part B, although not everyone needs a standalone PDP. For example, beneficiaries already enrolled in an MAPD plan, or certain other types of coverage, may already have prescription drug benefits included. Understanding which beneficiaries should enroll in a standalone plan ensures they have the right coverage for their needs. Part D plans cover prescription drugs, biologics, insulin, related medical supplies, and certain vaccines. Each plan uses a formulary, which is a list of covered drugs. Formularies are often organized into tiers that determine cost sharing, with generic drugs usually in lower tiers and brand name or specialty drugs in higher tiers. Plans must also cover at least 2 drugs in each therapeutic category, include generic and brand name options, and cover all or most drugs in 6 protected classes, which are categories of medications that treat life-sustaining or life-changing conditions. Every Part D plan includes a standard benefit, which consists of a deductible, an initial coverage phase, and catastrophic coverage once true out-of-pocket, or TROOP, costs reach a certain threshold. Some plans offer alternative benefits that are actuarially equivalent to the standard benefit, but may include enhancements like reduced deductibles, lower coinsurance, or coverage for additional drugs. Special rules also limit costs for insulin and adult vaccines, ensuring beneficiaries pay no more than set amounts in any coverage phase. Part D plans operate through pharmacy networks, including retail, long-term care, and mail-order pharmacies. Plans may designate preferred pharmacies that offer lower cost sharing, and enrollees typically must use network pharmacies for covered drugs, though out-of-network coverage may be available in certain situations. Premiums vary by plan, and beneficiaries can pay through monthly electronic payments, direct billing, or Social Security benefit withholding. Late enrollment penalties apply for those who do not maintain creditable drug coverage and delay Part D enrollment, except for beneficiaries who qualify for low-income assistance. To manage costs and ensure safety, Part D plans use tools like step therapy, prior authorization, quantity limits, and substitution rules. Transition rules allow beneficiaries to temporarily continue medications when switching plans or when drugs are removed from a formulary. Enrollees also have rights to request coverage for non-formulary drugs, request exceptions, and file grievances if they have issues with their plan or pharmacy. For beneficiaries with limited income and resources, assistance programs like Extra Help, state pharmaceutical assistance programs, and the LINET program can reduce premiums and out-of-pocket costs. Understanding creditable coverage is also critical, especially for those with employer or union drug plans, to avoid penalties. Part D coverage may interact with Medicaid, and certain employer, union, or federal plans may count as creditable coverage. Recent updates under the Inflation Reduction Act and for 2026 include capping out-of-pocket costs at $2,000, eliminating the coverage gap, and introducing Medicare price negotiations for selected high-cost drugs. The new Medicare Prescription Payment Plan allows beneficiaries to pay cost-sharing amounts in monthly installments, making prescription drug costs more predictable. By understanding these basics, you'll be able to guide beneficiaries in choosing the right plan, managing their costs, and accessing the medications they need throughout the year. Before we dive into the main sections, let's review the key changes for 2026. As part of the Inflation Reduction Act, Congress made important updates to Medicare Part D, including the elimination of the coverage gap and the capping of out-of-pocket costs for beneficiaries. One major update is the Medicare Price Negotiation Program. This allows Medicare to directly negotiate prices for certain high-cost single-source drugs that don't have generic or biosimilar competition. For 2026, CMS has selected 10 Part D drugs for the first cycle of negotiated pricing. During the initial coverage phase, CMS will provide Part D plans with a subsidy covering 10% of the negotiated drug costs. Then, in the catastrophic phase, CMS will cover 40% of reinsurance for those drugs. These changes don't affect what beneficiaries pay directly. They continue to benefit from lower out-of-pocket costs due to the coverage gap elimination and the cap on annual spending. However, the negotiated prices will affect the overall cost of these drugs within the Part D program. Let's start with the basics of Medicare Part D, which provides coverage for certain prescription drugs, diabetic supplies, and vaccines. Unlike original Medicare, Part D is offered only through private companies. There's no fee-for-service option. Part D coverage comes in several forms. The most common is the Standalone Prescription Drug Plan, or PDP, which covers only medications. Then there are Medicare Advantage Prescription Drug Plans, or MAPDs, which combine regular Medicare benefits with prescription drug coverage in one plan. Some Medicare cost plans, called Cost PDs, also offer Part D coverage as an optional benefit. Finally, PACE plans can include Part D as part of their services for eligible beneficiaries. To be eligible for Part D, individuals must be entitled to Part A and/or enrolled under Part B, not including enrollment in Part B solely for coverage of immunosuppressive drugs, and a U.S. citizen or lawfully present in the United States on or before the enrollment effective date. CMS makes this determination. Individuals meeting the above criteria are generally eligible to obtain Part D benefits through any PDP offered in the area in which the individual permanently resides, depending on how they receive their Medicare benefits. PDPs must enroll any eligible beneficiary who applies regardless of health status. To obtain Part D benefits from other types of Medicare health plans, such as an MAPD, Medicare Cost Plan, or PACE plan, the individual will have to meet the additional eligibility criteria for those plans. For example, to enroll in an MAPD, individuals must be both entitled to Part A and enrolled in Part B. Let's review who is eligible for Medicare Part D. To qualify, an individual must have Medicare Part A or be enrolled in Part B, although enrollment in Part B solely for coverage of certain immunosuppressive drugs does not count. In addition, the individual must be a U.S. citizen or lawfully present in the country on or before the start date of their coverage. CMS is responsible for determining whether these requirements are met. Once these criteria are met, most beneficiaries can enroll in a Standalone Prescription Drug Plan, or PDP, in the area where they permanently reside. PDPs are required to accept all eligible applicants, regardless of health status. However, eligibility for a PDP also depends on how a beneficiary receives their Medicare benefits. Generally, beneficiaries enrolled in Original Medicare, a Medicare Advantage Medical Savings Account Plan, MAMSA, a Private Fee-for-Service Plan, PFFS, or a cost plan may enroll in a standalone PDP. Those in an MAMSA plan can only receive Part D benefits through a standalone PDP. Beneficiaries in a cost plan or MAPFFS plan may receive Part D benefits either through their plan, if offered, or through a standalone PDP. Beneficiaries enrolled in an MAHMO or PPO can only receive Part D benefits through their MA plan. In some cases, individuals covered by an employer group plan may have additional options. Those enrolled in a PACE plan receive Part D benefits exclusively through their plan. Medicare Part D plans provide coverage for a variety of prescription medications and related products. This includes traditional prescription drugs as well as biologics, which are medications derived from natural sources, such as humans, animals, or microorganisms rather than being chemically synthesized. Examples of biologics include allergy shots and gene therapies. Part D also covers insulin and the medical supplies needed to administer it, such as syringes, needles, alcohol swabs, gauze, and devices used to deliver insulin into the body, like inhalation chambers. In addition, Part D covers certain vaccines that are not included under Part B, such as vaccines for shingles, respiratory syncytial virus, RSV, and tetanus, diphtheria, whooping cough. Not all drugs are covered under Medicare. Part D, excluded from coverage, are medications for weight loss or gain, fertility treatments, cosmetic purposes, and drugs used for the symptomatic relief of coughs and colds. Prescription vitamins and minerals are generally not covered, with the exceptions of prenatal vitamins and certain fluoride preparations, while most vitamin D analogs, including D2 and D3, are excluded. Medical foods that are consumed or administered under a physician's supervision but are not regulated as drugs under federal law are also excluded. Drugs for erectile dysfunction used for sexual purposes, non-prescription medications, some off-label uses, and drugs already covered under Medicare Parts A or B are not included. However, Part D plans are allowed to offer supplemental benefits for certain drugs that meet the definition of a Part D prescription drug but are normally excluded. For example, some plans may cover specific prescribed weight loss medications as an extra benefit. Part D plans do not cover every drug in every category, since multiple medications often treat the same condition. Instead, each plan develops a list of covered drugs called a formulary, carefully designed by pharmacists, doctors, and other experts to provide safe and effective treatment options. Formularies must include at least 2 drugs in each therapeutic category and cover both generic and brand name options. In addition, plans are required to include all or nearly all drugs in 6 protected classes, which treat life-changing or life-sustaining conditions. These classes include antidepressants, antipsychotics, anticonvulsants, immunosuppressants for preventing organ transplant rejection, antiretroviral drugs for HIV, and anti-neoplastics for cancer, ensuring beneficiaries have access to critical medications. For drugs selected under Medicare price negotiations, Part D plans must initially include them on their formularies during the period when the negotiated maximum fair price applies. Under certain circumstances, however, a plan may remove a drug, such as replacing a brand-name drug with a generic version that was not available when the formulary was first submitted, as long as all regulatory requirements for making changes are met. This structured approach helps Part D plans provide comprehensive coverage while managing costs and promoting safe, effective drug use. A key feature of Part D plans is the use of cost-sharing tiers, which group drugs into different levels that determine how much a beneficiary pays. Most plans organize medications into 3 or 4 tiers. Typically, Tier 1 includes generic drugs with the lowest cost sharing. Tier 2 includes preferred brand name drugs. Tier 3 covers non-preferred brand name drugs. And Tier 4 includes high-cost or specialty drugs. When helping a beneficiary choose a Part D plan, it's important not only to check that their medications are on the plan's formulary, but also to understand which tier each drug falls into, as this directly affects out-of-pocket costs. All Part D plans are required to provide at least the standard Part D benefit or an actuarially equivalent alternative benefit. The standard benefit is structured in phases, beginning with a deductible, followed by the initial coverage phase, which lasts until the beneficiary reaches the annual out-of-pocket threshold. Once this threshold is met, the catastrophic coverage phase begins, substantially reducing the beneficiary's cost sharing for the remainder of the year. Alternative coverage refers to Part D plans that do not follow the standard benefit design but are actuarially equivalent, meaning the total value of the benefits is at least equal to standard coverage. These plans must ensure that the annual deductible does not exceed the standard amount, and that cost sharing continues after reaching the out-of-pocket threshold. Alternative plans may include some or all of the standard coverage phases and, in some cases, offer enhanced benefits for an additional monthly premium. Enhancements can include reduced deductibles, coverage of drugs normally excluded from the plan, or lower coinsurance during the initial coverage phase, providing beneficiaries with additional savings and flexibility. For 2026, the standard Part D benefit begins with a deductible of $615, which the beneficiary must pay in full before any coverage applies. After the deductible is met, the plan enters the initial coverage phase. During this phase, beneficiaries are responsible for 25% of the cost of their prescription drugs, while the plan and, in some cases, drug manufacturers and CMS pay the remainder. As beneficiaries pay for their prescriptions, these out-of-pocket expenses accumulate toward the annual out-of-pocket threshold, known as true out-of-pocket costs, or TROOP. TROOP includes amounts the beneficiary pays directly, and in some situations, certain payments made by others may also count toward this threshold. Once a beneficiary's TROOP reaches $2,100, they enter the catastrophic coverage phase. At this stage, the beneficiary's cost sharing drops dramatically, and they no longer pay for covered drugs for the remainder of the plan year. This structure protects beneficiaries from very high prescription drug costs while providing a predictable progression of spending during the earlier phases of coverage. Special cost-sharing rules apply for certain drugs in 2026. For example, adult vaccines recommended by the Advisory Committee on Immunization Practices, such as shingles, TDAP, and RSV vaccines, are covered with no cost sharing even during the deductible phase. Additionally, for covered insulin products, the out-of-pocket cost for a 1-month supply cannot exceed $35 in any coverage phase, helping beneficiaries manage ongoing medication costs. Medicare Part D includes special rules for certain vaccines and insulin. Adult vaccines recommended by the Advisory Committee on Immunization Practices, or ACIP, are covered with no cost sharing, even if the beneficiary is in the deductible phase and whether the vaccine is received from an in-network or out-of-network provider. This includes vaccines for shingles, tetanus diphtheria pertussis, TDAP, and respiratory syncytial virus, or RSV. In addition, the cost sharing for a 1-month supply of a covered insulin product cannot exceed $35, regardless of which phase of coverage the beneficiary is in. Under Medicare Part D, payments for drugs are shared among the Part D sponsor, the manufacturer, and CMS, and the distribution varies by coverage phase. During the initial coverage phase, the Part D sponsor typically covers 65% of the cost for drugs selected for negotiation, and 75% of the cost for all other Part D drugs. Manufacturers contribute through a discount program, usually paying 10% of the cost for applicable drugs. CMS provides a subsidy equal to 10% of the negotiated price for selected drugs during the period the negotiated price applies. In the catastrophic coverage phase, the Part D sponsor generally pays 60% of the cost for all Part D drugs. Manufacturers provide a discount, typically around 20%, and CMS covers the remaining costs through a reinsurance subsidy, paying 20% for applicable drugs and 40% for all other Part D drugs during the price applicability period. This system helps manage costs and ensures beneficiaries are protected from high out-of-pocket expenses. True out-of-pocket costs, or TROOP, are the expenses that count toward a beneficiary's annual out-of-pocket threshold under Part D. These costs determine when a beneficiary moves into the catastrophic coverage phase, where cost sharing is greatly reduced. TROOP generally includes amounts paid by the beneficiary for covered drugs, but there are some costs that do not count toward this threshold. Understanding what counts and what is excluded is important for accurately tracking progress toward catastrophic coverage. Part D coverage is generally provided through a network of contracted pharmacies within the plan's service area. Although private fee-for-service, or PFFS, plans are not required to have a network, but may choose to do so voluntarily. Network pharmacies can include retail locations, long-term care pharmacies, and mail-order pharmacies. Some network pharmacies may be designated as preferred, offering lower cost sharing compared with other in-network pharmacies. Beneficiaries are generally expected to fill their prescriptions at network pharmacies, but under certain circumstances, they may use out-of-network pharmacies. This could occur if the beneficiary is traveling outside their plan's service area, loses a drug, or faces limited access to medications through in-network pharmacies. Using an out-of-network pharmacy may result in higher out-of-pocket costs. Part D plans may charge a monthly premium, and typically, plans with higher premiums offer lower out-of-pocket costs for covered drugs. Beneficiaries have three main options for paying their Part D premium. They can set up an automatic electronic payment from a checking or savings account or charge it to a credit or debit card. They can pay directly through monthly billing from the plan, or they can have the premium automatically deducted from their Social Security benefit check. It usually takes 2 to 3 months for Social Security withholding to begin or end, and when it starts, it will cover any premiums owed from the previous months. Generally, beneficiaries must stick with the payment method they choose for the entire year. If no option is selected, the plan will bill the beneficiary directly each month. Medicare requires non-Medicare insurers to notify beneficiaries each year whether their prescription drug coverage is considered creditable, meaning it is expected to pay, on average, at least as much as Medicare's standard Part D coverage. Beneficiaries may face a late enrollment penalty if they do not have creditable coverage and fail to enroll in Part D when first eligible. Specifically, if there are 63 or more continuous days after a beneficiary's initial enrollment period during which they did not have Part D or other creditable coverage, a penalty applies. The penalty is calculated as 1% of the national average Part D premium for each month without coverage, and generally continues for as long as the beneficiary maintains Medicare prescription drug coverage. Beneficiaries who qualify for the low-income subsidy are exempt from this penalty. In addition to formularies and cost-sharing tiers, Part D plans use a variety of tools to manage prescription drug benefits. Step therapy requires beneficiaries to try one or more lower-cost drugs before more expensive options are covered, if appropriate. Prior authorization requires a doctor to request approval from the plan before a drug will be covered, demonstrating that it is medically necessary. Quantity limits may be applied to certain medications for safety or cost reasons, restricting the amount covered over a specified time period. Plans may also substitute generic drugs for brand-name drugs when the generic has the same or lower cost sharing and certain conditions are met. Finally, under programs authorized by the Comprehensive Addiction and Recovery Act, plans may limit which prescribers or pharmacies a beneficiary can use to help manage medications at risk for misuse or abuse, such as opioids. Part D plans are required to provide a one-time temporary supply of certain drugs under specific circumstances, a process known as a transition refill. This applies to non-formulary drugs or drugs on the plan's formulary that require prior authorization, step therapy, or are subject to quantity limits that are not safety-related. Transition refills are available to beneficiaries who are newly enrolling in Part D, those switching plans, and current enrollees who are affected by certain formulary changes, excluding cases where a generic substitute replaces a brand-name drug. This ensures that beneficiaries can continue taking their medications while the plan processes coverage requirements. Beneficiaries eligible for a transition refill must receive at least a 1-month supply of their non-formulary drug, unless a smaller amount was prescribed during the first 90 days following enrollment, a plan change, or a formulary update. Transition refills only apply to medications the beneficiary was already taking and do not cover new prescriptions. During this transition period, the plan does not enforce prior authorization, non-safety-based quantity limits, or step therapy rules for these drugs. Additionally, the beneficiary and their physician can request an exception to continue coverage of the non-formulary drug or choose to transition to a formulary alternative. This process ensures continuity of care while the plan addresses coverage requirements. Part D plans are required to give enrollees the option to pay their cost-sharing amounts, including deductibles, co-payments, and co-insurance, in monthly installments over the plan year rather than paying the full amount at the pharmacy. Beneficiaries can opt into the Medicare Prescription Payment Plan at the beginning of the year or at any time during the year. Those who participate pay nothing at the point of service for covered drugs, but their plan will bill them monthly. Monthly payments begin only after the beneficiary opts into the program and first incurs out-of-pocket costs for Part D drugs. The plan sets a maximum monthly cap for these payments, which is based on the beneficiary's total costs and the timing of their enrollment in the program, so the cap may vary from month to month. Choosing to participate in the program does not affect how a beneficiary progresses through the standard Part D benefit phases, deductible, initial coverage, and catastrophic coverage, nor does it change what counts toward true out-of-pocket costs. The Medicare Prescription Payment Plan is available to all Part D enrollees, though it is generally most beneficial for those who face high out-of-pocket costs early in the plan year. Beneficiaries with lower or moderate recurring costs, such as those taking maintenance medications that are not expected to exceed the annual out-of-pocket threshold, may see little benefit, since their costs are already spread throughout the year. Enrollees can opt out of the program at any time, but they will continue to be billed monthly for any outstanding cost-sharing amounts. If monthly payments are not made, the beneficiary may be disenrolled from the program, though not from the Part D plan itself, after a specified grace period. The plan may also allow the beneficiary to repay the full remaining balance in a lump sum. Once a beneficiary leaves the program, they must resume paying their out-of-pocket costs at the point of service. Part D enrollees have specific rights designed to ensure access to prescription medications and fair treatment under their plan. Beneficiaries have the right to request coverage of a drug, request an exception if a drug is not on the plan's formulary or is subject to certain restrictions, and to file grievances if they experience problems with their plan or pharmacy. Understanding these rights helps beneficiaries navigate their coverage and ensures they can access the medications they need. Beneficiaries with limited income and resources should be encouraged to apply for the low-income subsidy, also known as Extra Help, through their state Medicaid office or the Social Security Administration. Applications can be submitted at any time. When applying through the state Medicaid office, Eligibility for other low-income assistance programs may also be reviewed. Beneficiaries can also contact Social Security directly by calling 1-800-772-1213, or TTY users can call 1-800-3-250-778. Applications can also be completed online at the Social Security website. Once approved by SSA or the state, Extra Help becomes effective on the first day of the month in which the application was submitted, providing immediate assistance with Part D costs. Some individuals automatically qualify for the Extra Help program without needing to apply. This includes beneficiaries who have full Medicaid coverage, those who receive assistance from a Medicare savings program that helps pay their Part B premiums, and individuals receiving Supplemental Security Income, or SSI, benefits. Medicare notifies these individuals by mailing a purple letter to confirm their automatic qualification. Beneficiaries should keep this letter for their records, and no separate application for Extra Help is necessary if they receive it. Beneficiaries with limited income and resources may qualify for the Low-Income Subsidy, or LIS, which helps cover all or part of their Part D premiums and cost sharing. To qualify in 2025, an individual's income generally cannot exceed 150% of the federal poverty level, which varies by state, and resources cannot exceed a set limit. Counted resources include bank accounts, stocks, bonds, other liquid assets that can be converted to cash within 20 days, and real estate that is not the beneficiary's primary residence. For most states and Washington, D.C., the 2025 income limits are $23,475 for an individual and $31,725 for a couple. Higher limits apply in Alaska and Hawaii. The resource limits for 2025 are $16,100 for an individual and $32,130 for a couple. These limits increase by $1,500 per person if the beneficiary notifies Social Security that some resources are expected to be used for burial expenses. In addition to Extra Help, some pharmaceutical manufacturers offer programs that assist low-income individuals in obtaining medications at reduced or no cost. Certain states also have assistance programs specifically designed for their residents. Some of these programs are considered Qualified State Pharmaceutical Assistance Programs, or SPAPs, meaning their payments count toward a beneficiary's true out-of-pocket, or TROOP costs, while others do not. Familiarity with these state programs can help you guide beneficiaries in managing prescription drug cost sharing and accessing the medications they need. The Limited Income, Newly Eligible Transition, or LI-NET, program provides temporary Medicare, Part D coverage for people with low income who are newly eligible for Medicare and not yet enrolled in a Part D plan. LI-NET offers coverage retroactively for certain groups. Full benefit. Dual eligible and SSI-only beneficiaries may receive coverage for up to 36 months in the past, while low-income subsidy-eligible beneficiaries can receive coverage at the pharmacy counter and for up to 30 days prior. If a beneficiary paid out-of-pocket for prescription drugs after qualifying for Medicare and Medicaid or SSI, but before enrolling in a Part D plan, they may be able to receive reimbursement for those costs. LINET application forms are available online through the Centers for Medicare and Medicaid Services website. Employer and union prescription drug coverage may be considered creditable, meaning it is expected to cover, on average, at least as much as Medicare's standard Part D plan. Employers and unions notify employees annually whether their coverage is creditable. If a beneficiary maintains creditable coverage, they will not face a late enrollment penalty if they later lose or drop that coverage and enroll in Part D within 63 days. If the coverage is not creditable, The beneficiary must enroll in Part D during their initial eligibility period to avoid a penalty. Beneficiaries with creditable drug coverage through programs like TRICARE, the VA, or the Federal Employees Health Benefits Program can compare that coverage with Part D options to decide whether to enroll. It is important for beneficiaries to check with their employer or union benefits administrator before making any changes, as dropping coverage could mean losing both prescription and health benefits. No late enrollment penalty applies if a beneficiary retires or otherwise loses creditable employer or union coverage and enrolls in a Part D plan or obtains other creditable coverage within 63 days. When a Medicaid beneficiary becomes eligible for Medicare, Part D prescription drug coverage shifts from Medicaid to Medicare once the beneficiary enrolls in a Part D plan. If the beneficiary does not actively choose a plan, Medicare will automatically select one on their behalf to ensure continuous drug coverage. In this module, we explored the essentials of Medicare Part D, the program that provides prescription drug coverage to Medicare beneficiaries. We began with the basics, including the two main types of Part D plans: standalone prescription drug plans, or PDPs, which provide drug coverage only, and Medicare Advantage prescription drug plans, or MAPDs, which combine Medicare health benefits with prescription drug coverage. Eligibility for Part D generally requires enrollment in Medicare Part A or Part B and being a U.S. citizen or lawfully present in the country. Some beneficiaries, depending on the type of Medicare coverage they have, may not need a standalone plan. We then reviewed the types of drugs covered under Part D, which include prescription medications, certain biologics, insulin and related supplies, and vaccines not covered under Part B. Drugs not covered include those for cosmetic purposes, vitamins in most cases, erectile dysfunction when used for sexual dysfunction, and certain non-prescription or off-label drugs. A key part of Part D is the formulary, a list of covered drugs developed by experts. Formularies must include both generic and brand-name drugs, cover all or nearly all drugs in 6 protected classes, and follow rules for drugs selected under Medicare price negotiations. Formularies also use tiered cost sharing, which groups drugs into different levels that determine how much beneficiaries pay, typically with generic drugs on lower tiers and specialty or high-cost drugs on higher tiers. All Part D plans must provide at least the standard benefit, which is organized into phases: a deductible, an initial coverage phase with cost sharing, and catastrophic coverage once the annual out-of-pocket threshold is reached. Alternative coverage is allowed as long as it is actuarially equivalent to the standard benefit, and some plans offer enhanced coverage for an additional premium. True out-of-pocket costs, or TROOP, track what a beneficiary spends toward reaching catastrophic coverage. Special cost-sharing rules exist for certain drugs, such as a $35 cap for a month's supply of insulin and no cost-sharing for recommended adult vaccines. We also covered how Part D premiums are paid, the potential for late enrollment penalties if beneficiaries do not maintain creditable drug coverage, and the variety of drug management tools plans use, including step therapy, prior authorization, quantity limits, and substitution. Transition rules allow beneficiaries who are newly enrolling or switching plans to receive temporary coverage for drugs they are already taking, even if the drug is non-formulary or subject to utilization management. The Medicare Prescription Payment Plan allows enrollees to spread their out-of-pocket costs over the year instead of paying at the pharmacy, which can benefit those with high drug costs early in the year. Beneficiaries also have rights under Part D, including requesting coverage of non-formulary drugs, filing exceptions and appeals, and submitting grievances if there are issues with the plan or pharmacy. For beneficiaries with limited income and resources, There are assistance programs such as the Low-Income Subsidy, state pharmaceutical assistance programs, and the LINET program, which help cover premiums and cost sharing. It is also important for beneficiaries with employer or union drug coverage to understand creditable coverage to avoid late enrollment penalties. Part D interacts with Medicaid in certain situations, and the new Medicare Drug Price Negotiation Program aims to reduce costs. Notably, beneficiary out-of-pocket costs are capped at $2,000, and the Medicare Prescription Payment Plan helps make costs more predictable. Overall, understanding these components enables beneficiaries to choose the right plan, manage their drug costs effectively, and take full advantage of the benefits offered under Medicare Part D.